Good morning, everyone, and welcome to today's meeting. I would like to welcome you all today. I would like to introduce our guest today, Dr. Marcos Hussam Ahrens. Dr. Ahrens has been graduated and was trained in University Hospital of Münster, and he's a senior consultant in the Department of Microbiology and Infectious Diseases at University Hospital Münster in Germany. He's an active member in the German and European Society of Microbiology and Infectious Disease, and also active member in the German Society of Internal Medicine. Dr. Ahrens, you have the microphone.
Okay, thank you very much, Khaled, for the kind introduction. Good morning and assalamu alaikum to my dear colleagues in Egypt. As Khaled told you already, I've been working for the last 5 years as a full member of the Antibiotic Stewardship team at our hospital. I'm quite sure that some of you have probably never heard of antibiotic stewardship or antimicrobial stewardship, which is the same. It's about the same in Germany. Lots of doctors still don't know about it. Antibiotic stewardship is some kind of campaign that started nearly 20 years ago in the USA and encompasses all kinds of measures to improve the usage of antibiotics with the aim to fight antimicrobial resistance to antibiotics. Okay. Yeah, okay. First of all, I would like to show you what we are doing as an ABS team. I will just use this abbreviation ABS for antibiotic stewardship. The core of our team consists of 3 people, who you can see there in the picture, 2 colleagues and me. The other 2 are a clinical pharmacist and an intensive care specialist, who is a specialist in infectious diseases as well, just like me. We all attended multiple ABS courses and acquired an expert certificate. But we are also supported by our colleagues from the microbiology department and the Department of Infection Control. Our main job is to do clinical rounds to all our intensive care units and many normal wards as well. For those rounds, our team usually consists of 3 people, 2 members from the core team and 1 colleague from the institutes. Before we go to the wards, we prepare ourselves by looking through the electronic charts of every patient who is on antibiotics and make notes. On the wards, we discuss all the patients who get antibiotics or antifungals with our colleagues who are in charge of the patients and tell them what we recommend. We only give advice. They don't have to follow, but because we always explain in detail, including guideline recommendations and latest evidence from studies, our colleagues are usually very happy that we are coming because they can learn a lot from us. If they wish, we also give lectures for the whole department from time to time. But we can't go to all the wards, and for some, it wouldn't make much sense because the prescription rate of antibiotics is too low, such as in the cardiology or ophthalmology department, or for psychiatry, for example. But whenever they have a question or seek advice, they can always give us a call. We also establish local guidelines together with the different departments. The requirements or the basis for all for that are the yearly reports of resistance for the whole hospital, but also for every single department, which we get from our microbiology institute. It doesn't help to read about the guideline recommendations from a country that has a very different rate of resistance. We also do a surveillance of the antibiotic consumption of our hospital on the whole and every department alone, and can compare it to about 30 other university hospitals of our country within some national surveillance program. Our aims are, first of all, the improvement of the quality of the antibiotics prescriptions in order to improve the outcome of every single patient by giving them the best drug in the best dosage for that specific patient and also for the right duration. The other aim is to prevent the development of resistance as much as possible, which does not only help the patient we are treating, but also society. And these 2 aims go together very well. Some people might think that you get the best outcome for your patient if you give them a lot of broad spectrum antibiotics. But what they don't realize is that they harm these patients more than they help them. But why is there a need for antibiotic stewardship? Why is there a need for such a campaign to fight antimicrobial resistance? Whenever you expose a towards these antibiotics by mutations. It is a phenomenon that has been known for a long time. Quite soon after the first antibiotics were available in the world, you could find bacteria that developed resistance mechanisms against the antibiotics, making them ineffective. In the second half of the last century, these developments of resistance, however, did not cause too much sorrow because there were always new antibiotics already available that were effective. For example, if you had an E. coli isolate that was resistant to amoxicillin, you could give a cephalosporin, for example. But towards the end of the last centuries, more and more enterobacteria became resistant to cephalosporins and penicillins, so that one had to resort to carbapenems, which had been some kind of universal weapon for gram-negatives for quite some time. But nowadays, more and more bacteria are becoming resistant towards carbapenems in many parts of the world, leaving very few options for treatment. Because in the last 20 years, very few new antibiotics entered the market and not a single new antibiotic class. The only new drug on the market are combinations of cephalosporins or carbapenems plus beta-lactamase inhibitors. But naturally, even towards those new antibiotics, resistances have been developed by bacteria already. So we had to change the approach, we handle antibiotics. We have all been far too lavish, careless, and indiscriminate. It is well known that a considerable percentage of antibiotic prescriptions are inadequate. The most frequent mistakes in prescribing are giving antibiotics when there's no indication, giving them too long, and using broad-spectrum antibiotics when you don't need them. Sometimes double and triple therapies are given, for which there is really rarely an indication, and quite often my colleagues and me of our ABS team tell our colleagues to change the dosage. But rarely do we tell them to reduce the dosage. Most of the time, we tell them to increase it. Giving a low dose of antibiotics increases the risk of not reaching the MIC, the minimal inhibition concentration. Beta-lactams, that are penicillins, cephalosporins, and carbapenems, are hardly toxic, so we are very generous when you're using them. We give high dosages, but keep the therapy short. Not too high, but the highest acceptable dosage. This is one important take-home message for you. The easiest way to induce resistance in bacteria is to give antibiotics for a long time in low concentrations. There have been numerous studies, as you can see, on false prescriptions of antibiotics. The correct use of antibiotics is, of course, to a certain extent subjective and arguable, but most authors agree that the rate of inadequate prescriptions is around 40%. The rising resistance worldwide is, according to the WHO, one of the biggest threats to mankind. Dr. Margaret Chan, who was the general director of the WHO at the time, outlined the future for us if we keep using antibiotics the way we have done before. We will have to face germs that are resistant to all the antibiotics available. That means we will become as powerless as 100 years ago when we had no antibiotics at all. Then even small routine operations can become a life-threatening risk. A large group of international scientists recently published this paper. They collected data from more than 200 countries of the world and calculated the number of deaths that are attributable to the fact that the causing bacteria are resistant to common antibiotics. The result was quite a large number, as you can see here, nearly 1.3 million deaths per year. I will briefly show you the situation we are having in Europe. All the pictures use the same color scheme. Blue means very low resistance rate, yellow mediocre, and red and brown colors indicate a high resistance rate. This country here is Germany. Well, there's my pointer here. This is Germany, and this is about where I'm sitting here in the northwestern part of Germany, somewhere here. On the first picture, you can see the rate of resistance of E. coli to third-generation cephalosporins, such as ceftriaxone or cefotaxime. In most countries, the resistance rate is around 10 to 15%. For Klebsiella pneumoniae, this looks slightly worse, especially in Eastern Europe, as you can see here. The carbapenem resistance for E. coli is non-existent in Germany, and also for Klebsiella pneumoniae, but not in Eastern and Southern Europe. 10 to 20% of the Pseudomonas aeruginosa samples are carbapenem resistant in Central Europe. This is one of the few species we can't treat very reliably with carbapenems. That is something we are not so happy about. Whereas Acinetobacter is hardly an issue in our country, as you can see here. Our MRSA rate is around 6% only. And the rate of penicillin resistance of pneumococcus as well. From these pictures, you may think that everything is fairly all right in Germany, but that is not the case. The resistant rate among gram-negative bacteria is rising, very slowly, but still rising. We have to make an effort. Not to get a situation like in Turkey or Greece or Egypt, I must say. In Germany, most of the German doctors know very little about antibiotics and resistance. It is not a big issue in our medical course. The problem is that quite a few people think that they know a lot about antibiotics, but actually they don't. I was the same, I must say. Only when I took part in the ABS expert courses, I realized how little I actually knew. So you need real experts who know the drugs and the spectrum, and you need to know which germs you are facing in all the different infections, and you need to know how high is their rate of resistance towards each drug. Antibiotic treatment is highly complex. Some of my colleagues only know about 3 to 5 antibiotics, which they give for any infection, and it doesn't matter if it is an infection of the bones, the lungs, the heart, the brain, or the skin. But most of my colleagues admit that they don't know much. These are the ones that are easy to work with. They want to know better and they listen to us. The difficult ones to deal with are the ones who think they know better, but actually don't know anything. So quite a big share of the antibiotics given in Germany and European hospitals and in outpatient clinics are not indicated. 1/3 to half of the patients are on antibiotics on average. Quite a few of them, however, receive more than one, which isn't necessary in half the cases. Another issue is the extended perioperative or surgical prophylaxis. It is still common in many surgical departments, although it doesn't make sense and is against all guidelines recommendations worldwide. It should be common practice to give perioperative prophylaxis at most for 24 hours. All guidelines tell you that. All evidence from research show you that. But still, many surgeons in Germany and worldwide prescribe antibiotics for longer, maybe 3 days, 5 days, or even longer. They mean well for the patients and consider it to be some kind of extra security to protect the patient from an infection. But what they don't realize, it harms the patient and the whole society considerably, and the patients don't benefit from it because extending the antibiotic prophylaxis does not help at all. But you're probably not really interested in the situation and problems we are facing in Germany. What is far more interesting to you is the situation you are having in your own country. I must say, I don't really know the situation in Egypt and how you deal with things over there. I've never been to any Egyptian hospital or in any outpatient clinic. I've only been there as a tourist once, and unfortunately, I didn't fall ill or had an accident. But I have read all the studies I could find on ABS, Antibiotic Stewardship, in Egypt. They are not very large in number yet, but ABS seems to be growing and more hospitals seem to develop ABS programs. First, I would like to start with the resistant rates in Egypt that were published in the last few years. This is the resistance rate. Where's my pointer here? This is the resistance rate you had more than 20 years ago here on the right. I use the same color schemes as in the slides I showed you earlier. On the left, to compare, I put the resistance rates we had at our hospital in Münster last year. Our resistance rate among antibacteria to 3rd generation cephalosporins and piperacillin and tazobactam, the favorite antibiotic of many of my colleagues because they don't know any other, is between 12 and 22%. That is not very bad, but it's not very good either. As a calculative or empiric therapy, that is without knowing the causing agent and the antibiogram, you should not use antibiotics that have a resistance rate of more than 15 or 20% as a rule of thumb. So we can still use these antibiotics for not so critical infections, but we are quite close to the border already. The situation in Egypt more than 20 years ago, however, didn't really allow you even then to use cephalosporins or piperacillin tazobactam as an empiric The resistant rate for E. coli Klebsiella pneumonia was already 40 to 65%. The good aspects then were a low quinolone resistance rate, for example, towards ciprofloxacin, and a very low carbapenem resistance rate towards meropenem and imipenem and all the others. But because cephalosporins and piperacin tazobactam hardly worked anymore, you probably had to use carbapenems all the time. So the resistance rate climbed drastically, which you can see here now. These are rough dates from a survey and several studies carried through from 2010 to 2017. As you can see, a lot has become even worse. And the most recent study I could find examined the resistant rates on an ICU of one of your biggest hospitals in Cairo. Not even carbapenems work in less than half of the cases. Please don't get me wrong. I don't mean to cause any offense at all. I do not want you to feel that I'm arrogant or condescending. I'm not condemning anything, but I also don't want to whitewash your situation. It looks very critical, I must say. You seem to be close to the situation that Dr. Margaret Chan outlined earlier in the summit I showed you. But it's not up to me to assess the reasons or draw conclusions, because I don't know your situation so well. That I leave up to the specialists from your own country. These are the conclusions the authors drew from their results. Al-Kholi called for nationwide surveillance program already in 2003. I don't know if it is established yet, but at least I found a notification in some other paper that there was a surveillance program going on for healthcare-associated infections and antimicrobial resistance called HAI, HAI. Surveillance is definitely an important thing, but it doesn't change the situation itself. Things need to be done. And I don't know how much has really happened after 2003 in your country. In 2018, Abdullah and colleagues called for a strict nationwide antimicrobial stewardship program. The lack of such a program, together with the misuse of antibiotics, not only in humans, and the lack of national control guidelines, they consider to be the main reasons for the increase in resistance. Fahim and colleagues mentioned the common practice of an overconsumption of antibiotics in the outpatient setting. They criticized that antibiotics are even handed out by pharmacies or pharmacists over the counter without prescription, although it is prohibited. That is definitely something that must be prevented by all means. The pharmacists probably mean well when they're doing it, but they can cause dramatic damage to the society. These are again the rates of resistance in figures this time, not in numbers. Forget about the numbers that are shown here. These are just the number of samples. It doesn't give you the percentage. This is not from an Egyptian study, but from a Lebanese research group who investigated a resistance situation in the countries of the Arab League altogether. But the numbers are the same as the ones I showed you before. On the left, you can see the rate of MRSA, and on the right, the rate of penicillin resistance in Streptococcus pneumoniae. And on this slide, you can see the rate of third-generation resistance in E. coli and Klebsiella on the left, and on the right, the rate of carbapenem resistance. On top for E. coli and Klebsiella, Pseudomonas in the middle, and Acinetobacter on the bottom. Here you can compare your situation to the other countries in the Arab League. But for some countries, there was very little data available. Gray means that there was no data. It doesn't mean that their resistance level is low. Last year, this interesting study was published. So it is quite a new study. It's from Rehab El-Sokari, who did quite a few good studies on the subject of ABS and seems to be one of your pioneers. She works in a microbiology institute in Sigazig. Maybe you know her already. This was a survey among 500 Egyptian doctors. More than half of them stated that they prescribe antibiotics every day. 60% were from the medical field, 30% from the surgical field, and 8% worked only in ICU. 1/4 from university hospitals, 50% from government hospitals. That was quite positive to see. Or what was quite positive to see was that nearly 1/4 of the hospitals already had ABS programs. Interestingly, 87% knew that antibiotic resistance is a global problem, but still only slightly more than 50% knew it was a problem in Egypt too. So quite a lot of people still didn't know how bad the situation actually is in your own country. And 50% thought that new antibiotics would solve the problem of resistance. Well, first of all, there are nearly none in the pipeline. And even if there were, and nothing would change if you don't change the way you're using antibiotics. You would just create new resistances towards the new drugs in no time. These were other questions they had to answer. All the wisdom questions were answered correctly by the majority, but about 30% couldn't answer each question correctly. Especially the question whether the length of an antibiotic treatment mattered for the development of resistance, only 60% answered correctly. But I guess if you made that survey in Germany, you would get similar results. There are also still people in Germany who teach the medical students and their colleagues that you always had to give antibiotics for a long time to prevent resistance, which is not logical at all and simply wrong. Please forget about that. Interestingly, 66% of the doctors admitted that there was an abuse of antibiotics in their workplace. The first step to solve a problem is always to realize that there is a problem. So that is very positive. The next question here is something I know very little about. In Germany, there are usually all antibiotics available unless there is a global shortage. I don't know what the situation is like in Egypt. I read also in other papers that you sometimes simply have to take what is there. That, of course, would be a big handicap. Most of the doctors answered the question correctly that antibiotics can cause harm. Of course they can. Yeah, apart from the development of resistance and damaging the microbiota of your guts, they can cause allergies, cause Clostridium difficile infections. Some can cause kidney failure, quite a few of them actually. Others liver damage, others can cause damage in the bone marrow and so forth. One should always keep in mind that antibiotics are cytostatic drugs. It's like a chemotherapy for bacteria. The next question, marked in purple, is also quite interesting. More than 1/3 of the doctors believed that the antibiotics in Egypt are of a bad quality. I don't know if that is true. Are they really produced over there? If I understand the authors of the study correctly, the quality is no worse than anywhere else, actually. In respect of the antibiotic use in Egyptian hospitals, I found this interesting study by Talat et al. And colleagues. They made a point prevalence survey in 18 hospitals in Egypt, including all kinds of departments of government and university hospitals. On average, 59% of all patients received at least one antibiotic, which is twice as much compared to some large European survey, which was done in 2009 in more than 20 European countries. The main reason for antibiotic use in this study was as a perioperative antibiotic prophylaxis, so surgical prophylaxis. In nearly 3/4 of the cases, the prophylaxis was given for longer than 24 hours. That mounts up to a lot of unjustifiedly prescribed antibiotics. I told you already that there is no evidence that giving the surgical prophylaxis for more than 1 day helps in preventing infections. Brad Spellberg is one of the most famous specialists in infectious diseases in the United States. He started the campaign Shorter is Better. In the last century, antibiotics were usually given for quite a long time. They didn't really care about resistance. Pneumonia, 2 weeks or more. Sepsis, 2 weeks or maybe 4 weeks. But then people realized that it has a lot of bad side effects, and the patients have to stay longer in the hospitals. In the last years, many trials were carried out comparing a shorter course of antibiotics with a longer one. Often 1 week versus 2 weeks. And nearly all the time, the shorter therapy is at least equal, if not even better. This is a list from his homepage, which summarizes the current evidence. We in our clinic nearly always treat patients, for example, with a pyelonephritis, so some severe urinary tract infection or pneumonia, no matter whether community acquired or in the hospital, for 5 days. 5 days only. And it works nearly always, all the time. Even on the ICU, doesn't matter. 5 days for pneumonia is enough for most of the cases, unless the patients are maybe highly immunocompromised. Then we give it for 7 days. Down here, you see the surgical prophylaxis. He listed up 55 randomized controlled trials, a huge number, showing that at most 1 day or single shot. Usually it should be single shot. If the operation goes on for longer, you give a second shot, but usually, or sometimes even a third shot, but at most 24 hours. And that is equal to a longer prophylaxis. It doesn't matter in outcome. On the same topic, I found this Egyptian study from Said and colleagues. It was an ABS intervention in 5 Egyptian hospitals to improve the surgical prophylaxis. That is to cut down the to only single shot or at most 1 day. What they did was mainly educating the surgical staff. And they were quite successful. Before their intervention, the duration of the antibiotic treatment was only correct in 3%. So only in 3% the antibiotics were given for less than 24 hours. Afterwards, after this intervention, it was correct in 29%. You may say 29 is still not great, but it's a huge improvement. Whenever you do ABS, you have to be patient with your colleagues. They won't do everything correctly suddenly if you tell them once. It's like that in Germany and probably like that in Egypt and in all the other countries. The authors tried to explain why the rate of correct prescriptions was so low. They criticize that the hospitals had no policies or guidelines and also that there were no regulations on a national basis. They also mention the wrong perception of the surgeons that the longer you give the patient an antibiotic, the longer or better is the protection from infection. The barriers they encountered for changing the behavior of the prescribers were poor awareness of antimicrobial resistance and the reluctance to change things. As I mentioned before, it is not easy to change someone's behavior. They are used to it and feel comfortable. One argument that you often hear in Germany as well, we have always done it like that, and why is there a need to change it now? But that, of course, is not really an argument. And also that belief and statement, that's all well and good, but what you say about the guidelines, but our patients are different from other people. Our patients are sicker. They need special treatment. That is very rarely true. What the authors also mention in the perception that you are facing an extremely unclean environment in Egypt, and that is why you have to give more antibiotics. Well, I don't know about the cleanliness in Egyptian operation theaters, but I don't think that you conduct your operations with unsterile tools. And even if it was like that, that still would not be a reason to extend your prophylaxis. 1 day would still be enough. Quite related to that issue is the argument that the spread of multi-resistance is not caused by antibiotics and the overuse given in hospitals, but by spreading it from patient to patient. So it's more some hygienical problem, and it has nothing to do with me as the doctor. That does happen, of course, but it is rarely the case. Most of the multi-resistance you find the patients bring along from outside the hospital already in their guts or on their skins. Or it is spread within the patient by giving antibiotics in the hospital. That was also shown in this study from Egypt. They examined the multi-resistant specimens from a ward and found that there was no relationship between the samples in 90%. And it's about the same in Germany. Yeah, so 90% is from the patient himself, and 10% maybe are passed on from other patients. Coming back to the study by Talat and colleagues, I also found the choice of antibiotics for the surgical prophylaxis quite interesting. For one, the biggest part were third generation cephalosporins, which isn't wrong for abdominal surgery in general, especially here in Europe. But as I showed you earlier, the majority of the germs on the skin and mucosal tissues in Egyptian patients are resistant to this antibiotic class. So it shouldn't have any impact. Secondly, no patients received glycopeptides such as vancomycin as a surgical prophylaxis, which should have been this purplish color here, which was used for other indications, but not for surgical prophylaxis, which was quite surprising to me. The main reason to give a surgical prophylaxis is to prevent surgical site infections, which are mainly caused by Staphylococcus aureus, at least as far as skin and soft tissue infections are concerned. And with your large amount of MRSA carriers, a glycopeptide should be included for most of your patients. That is also recommended in the current American guidelines, which I quoted here. As I said before, the biggest part of all antibiotics used in this study was for surgical prophylaxis. The second biggest part was for all kinds of community-acquired infections, pneumonia, UTI, etc. Number 3, and that surprised me too, was medical prophylaxis. At our hospital, very rarely antibiotics are given as a medical prophylaxis, apart from maybe the last point that is given here, because we have a lot of patients who have had a transplantation. So immunocompromised patients. The authors mentioned that a lot of antibiotics were given as a prophylaxis against pneumonia. There's no guideline in the world that I know of that recommends doing that, not even in high-risk patients. This is another interesting study by Rehab El-Sokhari. In this intervention, she and her colleagues tried to improve the practices in antimicrobial use on the ICU of a university clinic in Zagazig for device-associated infections, which are ventilator-associated pneumonia, catheter-associated urinary tract infections, and central line-associated bloodstream infections. It was thoroughly planned through. These are the interventions they made. First of all, they established an ABS team, including an intensivist, a microbiologist, which was probably herself maybe, an infection control consultant, and a clinical pharmacist. This is a complete ABS team, also by German recommendations and standards. But very rarely we find a full ABS team in our hospitals. What was very clever, they also included the medical director. That is something that is very important for any ABS intervention. You need the support of your boss. And if you go on ABS rounds on different wards, they should also be supported by the bosses of the departments you go to. Otherwise, you won't be able to change much. Here in this study, the boss was included, so it wasn't difficult to implement all the changes. Secondly, they changed their antibiograms. I couldn't find in what way. It wasn't really described in detail, but I assume that they created selective antibiograms which only showed the best options, that is, the more narrow antibiotics. Thirdly, they prepared guidelines. Then they also made restrictions for extensively broad spectrum antibiotics, which are given here. They also gave educational courses, not only to doctors, but also to nurses, which I also thought very thoughtful of them. And lastly, they improved their infection and control measures. This was done as some before and after intervention observational study. The control cases they collected from May till August 2016. Then they started the intervention, which went on for nearly a year, and then they collected new cases, eventually 120 cases in each arm of the study. These are the results. I don't really want to go into details, but as you can see here, they managed to improve all the aspects given here, and even significantly. But they did not only improve the clinical aspects, they also managed to reduce the costs, which is also a very good argument whenever you want to discuss certain measures with your bosses. And what is really astonishing, even the rate of multi-drug resistant germs went down. But you have to be careful about the interpretation of these results. This was only an observational study in a before and after design. So there's a big risk of bias. Usually it is very hard to reduce resistance in trials. That takes usually a long time and is very complex. But nonetheless, a very good result for this intervention and very well pulled through. In the survey I showed you earlier, they also asked the question, when do you order a microbiological culture? 69% answered only when the treatment fails. And that is a huge mistake, in my opinion. Even here in Germany, we try to get cultures done whenever possible from all kinds of fluids. Although with the resistance situation we are having here in Germany, the chances are quite good to choose an antibiotic that will work. Whenever you start an antibiotic treatment for a patient with a relevant infection, you have to get sets of blood cultures taken. In Egypt, with the current resistant situation that you're having now, the chances are fairly low that the drug you're taking will work, unless you always take your last resort colistin. But then you will have colistin-resistant germs soon and lots of kidney failures. If you don't know the germ and the resistant patterns, you will never be able to de-escalate your treatment and make your spectrum less broad. You will have to give broad spectrum antibiotics all the time. If your first choice doesn't work out, you will hopefully see why if you get the antibiogram. When you get the results back from the microbiology lab after 2 or 3 days. I don't know how long it will take in Egypt. In some studies, it seemed it took longer. There you could also maybe work on that. In Germany, if nothing grows within 2 or 3 days, you can be quite sure that it will be negative. If you still don't know the germ after these 2 or 3 days because you never sent in any cultures, you will have to try out the next broad spectrum antibiotic. That will make the treatment longer, cause more resistance, cause more side effects probably as well, and maybe will even put your patient in danger if it is some dangerous infection, because you can't know that your second line will also work, or will work because the first one didn't. This is a very pivotal point, I think. You have to involve your microbiology department as much as you can. And don't try to save money there. In the end, you will have to spend much more than otherwise. Blood cultures are essential for any severe disease, and make sure to take at least 2 sets. If you find a germ that is a normal resident of your skin in one blood culture, for example, Staphylococcus epidermidis, or epidermidis, I don't know how you pronounce it in English, it probably is a contamination. But if you find it in both, you should take this germ seriously. And taking 2 sets also increases your yield. It increases your chances to find a germ. Cultures taken from otherwise sterile compartments, such as blood and cerebrospinal fluid or joints, are far more reliable than samples taken from samples that are not sterile. The germs you find in samples from the lung, for example, are not necessarily pathogens. And especially if you find more than 1 germ in your urine samples, you can be sure that what you have is a contaminated urine sample. This is also why you should not take urine samples from patients that don't have symptoms of a UTI. And you should never take urine samples from patients that have a urine catheter, unless it was very newly put right away, just maybe 10 minutes ago, or let's say maybe 2 hours ago. But if it was even put yesterday, you can't use that urine anymore. You have to put a new catheter. So as the last slide, I would like to give you some kind of summary of the universal ABS rules. The first 2 rules actually belong together. Whenever you encounter a sick patient and you think he or she might have an infection, but you're not quite sure, you shouldn't give an antibiotic straight away. I see that quite often, especially among not so experienced doctors on our emergency admission unit. Very often, when they're not sure at all if there is an infection or not, they decide to give an antibiotic, apparently to be on the safe side, so that nobody can tell them later that they forgot something, or because they fear that the patient might deteriorate quickly and by the next morning the patient might be dead. But that is wrong. If you are in doubt, don't give antibiotics. Patients don't die like that easily or rapidly unless they're having a sepsis already when they're admitted. And you also have to be careful with highly immunocompromised patients. But usually you have time for diagnostics, and you can maybe go for watch and wait, at least for hours and maybe even for 1, 2, 3 days. Just keep a look on your patient and observe and be watchful for symptoms of a sepsis. The third point I have discussed already with you, I think, always keep in mind, shorter is usually better. Brett Spellberg even believes that many pneumonias can be treated by a single shot antibiotic. Whenever you give antibiotics, you should use narrow spectrum antibiotics if possible. That, of course, is difficult in Egypt with the resistances you are facing. But whenever you find the germs, the germ that is responsible for the infection and get an antibiogram, you should de-escalate to a more narrow spectrum if possible to avoid resistances against the broad spectrum antibiotic. And also to avoid side effects that broader spectrum antibiotics often cause. And what you should also keep in mind, a more narrow spectrum often means a more effective treatment as well. The strongest drugs against Staphylococcus aureus, for example, are the oxacillins, such as flucloxacillin or methicillin, and also cefazolin, for example, as a cephalosporin. So first generation cephalosporin. And whenever you can, use the good old penicillin, use it. It is a strong antibiotic if it is tested susceptible. Broad spectrum doesn't mean more powerful. It's actually quite the opposite most of the time, especially if you think of vancomycin, for example. It's not a very powerful drug. For some drugs and infections, you have to mind the tissue permeability for the drug. For example, some drugs don't really enter into the cerebral spinal fluid. Some don't go well into the bone. Or daptomycin, you can't use for lung infections, for example. For most cases, you don't need a double antibiotic therapy. For some infections, it makes sense to give more than one antibiotic to widen the spectrum. For example, if one is good for gram-negative germs and the other is good for gram-positive germs. But if you know the germ, very rarely you need more than one drug. You don't need to tackle it from two sides, basically. One exception is, for example, tuberculosis, where you need even 4. Yeah, but you probably know that very well. Rule number 7 is also probably a bit more difficult to follow for you than here in Germany. There are quite a few antibiotics that have an excellent resorption from the guts, and it doesn't make a difference if you give the drugs orally or IV, as long as the gut of the patient works normally. Quinolones, for example, or cotrimoxazole, or clindamycin, or linezolid. Whereas the beta-lactams usually have a low bioavailability and can hardly be oralized in severe infections at least. So that was my last slide, and now I'm curious for your questions and remarks.